Please welcome our panelists. Mike Marks, EVP and CFO at HCA Healthcare. Scott Hawig, Executive Vice President and Chief Financial Officer of BJC Health System and Secretary-Treasurer of the HFMA Board of Directors. Seema Verma, Executive Vice President and General Manager at Oracle Health and Life Sciences. Jason Wolf, President and CEO of the Barrel Institute. And Ann Jordan as today's moderator.
All right, everyone settle in, because this is going to be an outstanding discussion. We talked earlier today about bringing together stakeholders across the industry to have true discussions and look at solutions. You are actually going to see that play out live. And so first, we just thank this tremendous group for giving us your time and your insights. We're not going to mess around. We're going to go ahead and jump into the questions, because there's a lot to discuss. We just heard about policy, and so we're going to pick up on that theme a little bit. Scott, we're going to kick off with you. CFOs, you inherit a lot that you've got to work within. And so I'm going to ask you if you could change one aspect of today's payment or policy framework to better support long-term sustainability and outcomes, what would that be? What's realistically achievable because of this current political and economic environment? So you've got a big one. I'll let you address it as you see best.
All right. Thanks, Ann. Good morning. Good morning, HFMA. Thank you for having me. I'd start, I'm going to cheat because I'm going to give you two or three as part of that answer.
We'll allow it.
Part of that is thinking, Casey, for coming this morning and starting at the dialogue, because I think ultimately they start at a high level. There's been a lot of theme of getting all the interested parties together. Hopefully this panel is representation of that. To have a conversation, I'd say to settle on what's the right data definitions, what are the numbers we're all looking at, and then I'll say joint solutioning. Probably a lot of parallels to what you talked about in terms of the role HFMA can play. So I think step one is probably having more dialogue than we've had in the past. In terms of some of the comments from earlier this morning, and I'll bleed that into kind of my ultimate recommendation around infrastructure, is the balloon that's squeezed between commercial insurance, Medicaid, Medicare, and while one dynamic is riding with Medicaid, there's struggles in the industry on Medicare Advantage. While one dynamic is happening or ceilings are put on in commercial, where that balloon is squeezed. And so to me, that's a lead into why I think infrastructure is one of the tangible, near-term things we can work on. And what do I mean by that? I think Ann alluded to kind of a view of the industry when we recap over HFMA for the last 80 years. The core rails that the business runs on, I mean, claims adjudication and financial transactions are decades old. It could be 80 years old. Those are detached. So what I am trying to propose this morning is if we can get convening, if we can get organizations together, perhaps the ANSI codes could be dusted off in terms of standards. Perhaps the rails in which the technology runs and the bifurcation of clinical and financial and claims data, we could rethink how those bring together to reset the data that we then should have the conversation on. That's tangible. I think that's well aligned with objectives around interoperability, transparency, administrative simplicity. I think we get the benefit of kind of a triple win on that front.
Any follow-up from the panel?
No, I fully agree. I mean, I think we're at a moment of time where we have an opportunity. This topic also crosses over to affordability. One of our biggest challenges in this industry is the sheer amount of bureaucracy and manual exchange of data and lack of transparent rules that force providers and payers to bulk up on a lot of cost. And so if we can move to real-time digital data exchange based on standards, we have an opportunity to benefit our patients and the payers' members, and also each other by reducing this cost. And that will also produce a foundation that things like AI can operate against, as you noted in your opening comments. So this is an affordability play and a play to ensure that we serve our patients more effectively and more efficiently over time.
jump in and say totally agree with that. If you look at the numbers, we're spending 25 to 30% on administrative costs alone. And at the same time, I think the cancer ASCO conference was just last week, and they were talking about new cures and new treatments. And I think when we look at the system, we want to be able to give people the latest, greatest treatments and therapies. And so we don't want to ration care, but we do need to rationalize it. And so I think that there's a lot of opportunity, especially in the era of AI. But I do think it's important that we focus also on value-based care. I think that there's tremendous opportunity there as well, because you're fundamentally rethinking how we deliver care. Today, we're a sick system. We are built for when people get sick, and that's an opportunity to turn the page. And I think also the other piece I would add to this, when we talk about value-based care, I think sometimes it doesn't make sense because you're trying to, if you're running a hospital, you want people in the hospital. That's how the financial objectives and the incentives are set up. Well, we have to kind of think about this in a more complete way. At the same time, we're hearing that with clinical trials, for example, that there's no clinical trial capacity. And we are hearing that drug companies want to do more clinical trials, but they don't have capacity. So on one side, there's an opportunity with value-based care to keep people hopefully more healthy, preventative care out of the hospitals, but there's also an opportunity to use that capacity in the healthcare system to do more clinical trials and drive more research and innovation. So I think when we look at this, value-based care, AI, but the other piece of this is let's have a more holistic view of what's going on across the entire industry, not just one piece over here in health services delivery, but to look at the entire picture.
So talking about solutions that we just brought up, I'm going to segue a little bit more into affordability. Everyone's agreeing it's a crisis. I think now all the stakeholders are saying it from different angles, but obviously there's different perspectives among the stakeholders on what those solutions look like. So let's dissect some of those critical points surrounding the affordability discussion, and let's start with coverage. Mike, I'm going to look to you on this one. From your perspective, what is some of the critical issues around coverage that we need to address to really see affordability at the end of the day?
In Casey mentioned this too, but I do start with coverage. I mean, it's very difficult for just the average citizen in America to access affordable health care if they don't have insurance coverage. And so the importance of Medicare and Medicaid and employed-sponsored insurances and the exchanges really is the foundation of affordability. I do believe as providers, and I represent a provider, so I'll stick with that, but as a provider, though, we have to acknowledge that affordability is a real issue. And you can't change until you know where you're starting from. And so we start there. And so we believe that as providers, we have to take this seriously. And we have to accept and acknowledge that we've got to control the controllables here. And that means we need to be focused on efficiency. Internal to our organization, we need to have robust plans that drive efficiency and do it in a way that accelerates and enhances quality of care and transparency to our patients. And so keeping those three things in mind as we move forward, in addition to just advocating for coverage, we've got to own the change. And it's not going to happen just with the providers. It's going to happen in collaboration, which I think HFMA is really set up to help us do. I would also say, I think the payers also know this, and we're seeing really good response from many of our key payers to join this effort around data, around standards, around more transparent rules for processing. And collectively, we do have to own cost, and I think it's going to take the whole system working together to do that.
I can't bring up affordability and not call upon the affordability czar. As we look at solutions in the industry, what advice or perspective can you give us?
The private sector always does it so much better than the public sector. We've seen that fraud is rampant in these public programs because, as Milton Friedman said, they're spending other people's money on other people. So you're not going to be too concerned if a thief is digging in there. And there's been lots of I've even been surprised at how much fraud we've had. I mean, to the extent we have government setting guidelines and things to give people choice, particularly among these small businesses that I heard from, their choice is greatly restricted, and it varies by state. There's some of the blue states don't allow them to join together, small businesses to join together, so they could be in a self-funded, low-regulated, lower-price situation, short-term plans, and even models that don't involve insurance, other financing models. People should have choice around those things.
So I'm going to move on to the patient perspective. I want to thank Jason, first of all, for being here. I personally did not think it was fair to have a conversation on affordability without bringing the patient into the middle. Jason agreed to join us. Jason, we're listening, number one. What are you seeing as the leading concern of consumers?
Yeah, I appreciate the question, and it's just an honor to be here with everyone, and hello, HFMA. Can I ask a question of the audience? How many people here are human beings? I don't know why I always get a nervous laugh when I ask that question like it's a trick question, but I think the reality is, right, the foundation on which we build healthcare is this model of human beings caring for human beings. We know what we need, we know what's important, we know how to drive that conversation in a way that's meaningful. And I think a lot of what we heard so far is about the process burdens we've seen placed on healthcare, but we have to think about process burdens aren't only on the systems of healthcare that we operate. The process burdens are on our workforce, the process burdens are on the people that we expect to come into our systems, and as a result, I think there are really three areas that are impacting what we hear from consumers of care across the United States. We ask them twice a year what's in their way, and it's a very technical acronym, CAT. It's cost, access, and trust, right? And cost is an issue for people because of insurance premiums, like the things we talked about, finding the right path to accessibility, to good financing or support for their care, to the cost of premiums, the cost of co-pays is a huge conversation right now in, I think, the consumer world around how do I even enter into the healthcare system, which leads to the access issue. What we're finding is 1 in 5. So imagine if we all raised our hands in this room and then asked 1 in every 4 of you to put them down. 25% of the American citizens right now are opting out of healthcare due to cost, which means we can talk about value and we can talk about system redesign and we can talk about all those things, but if 1 in 4 people are just not getting healthcare, the extrapolation of the cost that has in the system, you were alluding to this before in your opening, is substantial. So part of the conversation we need to be having with healthcare consumers is how do we get them back? Part of it is system design, part of it is accessibility, but we have to figure out that piece as well. And then it's trust. This has all led to a trust challenge for healthcare. I think about 36% of Americans right now say they have great trust in the U.S. healthcare system. They trust our providers and our nurses a lot more than our systems and our structures. And as a result of that, they feel like the system is not there for them. So I think this conversation around redesign, if we simply have it around what we think structure should be, I think like you were alluding to before, Casey, it's not just a government solution. It is a conversation that brings together all these voices. But if we aren't listening to the consumer, like we do in private industry, to understand what engages people and has them be a viable customer in our system, the system in itself will fall in on its own weight. And I think that is the biggest challenge. When we have people opting out of care, we're not actually striving to achieve the best in outcomes that we're seeking to achieve in the first place. So we are stuck in the very paradox you introduced before.
CFOs, I kind of ask you on the spot, what are some of the efforts that you're seeing or living in terms of making sure that connection with the patient, with the community is there? Are you seeing change or more dedicated efforts going in that direction?
I can jump in there. I would say our effort on this front, and Jason mentioned it, is that counterplay between cost, access, allied competition, meaning we have over time introduced access points without bringing the public along into when they are the best spot to receive care. That then went against the dynamic of, call it, insurance or coverage decisions, which impacts the real-time choice, the different copay for different type settings, what is a deductible or what's not a deductible. and we provided very little navigation. So we put product or we put service out into the market, we thought well-intentioned, in order to create access, without much guidance on when and how to use it, which likely causes inefficiencies on our side. So a long-winded answer to say we spent probably more time narrowing in on our access points and navigation and education around when and how to use those settings. Now, technology ultimately has been a key driver in helping be able to do that efficiently. But for us, it's how do we get people to the right spot? Because they don't follow the business as closely as we do.
So let's move on to a topic I know is very fundamental to this audience, and that's optimizing the cost of care. You live it constantly. Healthcare finance has traditionally focused on cutting costs and protecting margins, but these times are changing, and the expectations you're feeling are rising. There is a push to accelerate the transition from volume to value. An essential partner in all of that is tech. And so, Seema, we're going to turn the conversation to you. Thank you for being here. Big conversation right now is AI. How do you see that AI is helping healthcare organizations reduce the cost of delivering high-quality care?
Sure. Well, I think it's fair to say, or to start to say, look, technology has not served the healthcare industry well, right? So let's just start there. When we talk about trust, do we even trust tech? Because I think if we look historically of what's been delivered, it's created a lot of problems, just in terms of silos, interoperability, and just burden. But I do think that AI is that promise. So when I think about my time at CMS and all the problems that we encountered in healthcare, and now I'm at Oracle and I'm thinking, how do we solve them? I can see a path that actually many of the problems that we're talking about can be solved with better technology. So we talked about efficiency, right? AI can do a lot of the burdensome manual work, whether it's ambient listening or revenue cycle. There's a lot of work that can be done, so we can kind of reduce that as well. But there's also opportunities around quality, right? So when we know now that there's uneven quality across the country, and it depends on where you go. But what about bringing better tools for providers that are delivering on the front line so that they know what's the latest clinical trial, what's the latest, or what exact preventative service the person needs, or what's the best treatment. So I think there's ability to bring that. And then that also addresses areas of access to care because we're able to up-level. So if we think about some of our paraprofessionals that make up a large part of our workforce, we are able to give them better tools so that they can deliver a higher level of quality of care. So you're addressing costs by bringing down a lot of the inefficiency, a lot of the waste. You're addressing quality of care, and you're also addressing access. So if we think about when you're building more capacity, your providers are not doing a lot of the manual burdensome work, they can actually see more patients. So if we think about ambient listening, I think many of you have experimented with that. And as we look at the data with ambient listening, it's not just building trust and the doctor being able to look the patient in the eye and delivering better care because of that interaction, but they're able to actually see more patients because they've become more efficient. And so it's things like that. And that's been probably one of the more widely used use cases that we can point to. Now think about bringing a lot more AI into the picture. So now when the physician goes in, there's a summary of the patient so that the doctor's not spending 20, 30 minutes looking through a medical record. Think about when the AI can actually give recommendations on coding. Think about when the AI can do prior authorization, and you start building in all of these AI agents all together, and the experience completely changes for the patient and the provider. So there's tremendous opportunity. What I worry about with AI is how our system is going to approach it. And we can already see that happening today. The reality is the infrastructure that we have today in the United States, for the most part, it's antiquated. And you can't bolt on new technology solutions to aging technology. And with AI, the AI is only as good as two things: the models that it was trained on, so the data that it was trained on, and then its access to real-time data. It has to have access to real-time data to give it context. So in clinical care, we think about maybe the AI is recommending a particular medication. But if the AI doesn't know whether the insurance company is going to cover it, whether that medication is even in stock, or is the patient allergic to have some potential interaction. So if you don't have access to real-time data, so if you're bolting on a solution, an AI solution, and that AI solution only has the data that's available in that particular instance, it's not going to work well, and you're not going to get the potential that AI can deliver if you're not doing it right. So bolting on solutions, taking modern technology and putting it onto old data or an old infrastructure isn't going to work well. And I think we run the risk of making a lot of investments in AI. So we bring on a bolt-on solution over here, we have a bolt-on solution over there. In our call center, we have one for revenue cycle. But if those agents are not talking to each other, if the data underneath the AI is not unified, then it's not going to work well. It may still work, it may give you a little bit of efficiency, but to really drive the transformation that we're talking about, you need to have a plan for unifying your data and bringing a more modern technology. And then the problem with that becomes, well, what about our old historical systems? And if you're going to get an AI platform, are we just layering new technology on top of old, and what is the cost? And so it's possible that you could erode all those potential efficiencies because you're spending so much money on technology. Mm-hmm. So I think we really have to be thinking about our purchasing decisions, what we're buying, and making investments in the actual infrastructure.
Because we have financial professionals in the room, let's sit on cost of care a little bit longer. A lot of investment going into technology. We brought up the figure, almost a $70 billion increase expected this year. So you got this investment on one side. You've got affordability on this side. You got big shifts in reimbursement rates going on. How are we balancing all this? How, at the end of the day, CFOs, do we look at that and say affordability? What's the navigation lanes?
Scott, you want this one or you want me to jump?
I thought I'd wait long enough for that.
I think it's one of the key questions that we are, as financial executives, are facing right now. The amount of technical debt, the amount of legacy systems that we're all dealing with are really getting in the way of transformation. I mentioned earlier the absolute requirement that we get to interoperability, data exchange with standards between key parties, including payers and providers. But even with that in place, the key that I'm finding in my company at least is the demand to invest in things like AI, automation, and transactional systems far outpaces any ability to pay for it. And so, we are facing that age-old dilemma. You guys are facing it every day too, which is, kind of scarce resources and tough choices. So it's forcing us to prioritize. And when I think about prioritization, we start with the patient. And so, part of our work here is ensuring that we have the right investment in our clinical systems, and then the data and infrastructure underneath our clinical systems to ensure that we are able to do things like automation and AI in an efficient way, in a way to where you actually see a return on investment. Not all returns on investment are financial. I mean, a lot of these returns on investment are quality of care and service. The biggest one that we're finding right now is reducing the administrative burden of doctors and nurses. It's a key component of why we're investing in technology. Taking care of patients in the modern healthcare system is way too burdensome and way too administrative. So that guides our focus. The second area is really operations. If you think about we saw 47 million patients last year. And you just think about the complexities of moving patients through emergency rooms and through inpatient units and surgical services areas. We have an incredible opportunity to drive towards using AI and automation to be more efficient, provide safer care, and do it in a way that is way more effective for all of the stakeholders in the business. But right now, as I think about it, it's about standards and it's about data. And, we get tempted to jump to really innovative, high-order ideas. And those are great. And we're eventually going to have to get to those. But we're going to fail if we don't recognize that you have to build the standards first. So getting the data right, getting the standards set correctly, and then working together with key partners, with technology, with payers, with policymakers, to really stay focused on those priorities is how I'm thinking about it. We can't do it all. And so we have to do the things we choose to do really well. And keeping that patient at the center of that, but also knowing that you have to drive towards a return on investment, clinically and financially, is a really good way to guide that decision.
And Case, I'd be interested in hearing, as we're navigating the complexity of cost of care and affordability, I think some people like to say, well, the government's going to sort it out for us. I do believe some people think that. How, in a frame of mind, should the industry view self-help versus when the government should step in? Is there guidance, so to speak, of where maybe that line should be?
I mean, it's a clear principle, and it's not coming from the affordability czar, not particularly. We have the Regulatory Flexibility Act. It's actually 50 years old now. Stresses the small companies. Innovation, we don't know where it comes from. It wouldn't be innovative if we knew what it was. And so having lots of small companies operate is very important. That's one of the areas of competition is so important. If we have a few big companies, they're going to be stuck on their things, and that blocks opportunity for some new things to be discovered. And that's true across industries. The Regulatory Flexibility Act is not just about healthcare, but now we're in an age with pressing problems, and technology's changing as we blink. It's really important to have a good ecosystem for the small companies.
So when we talk about cost, I think we got to call out payer-provider friction. We know this well. And that results in a remarkable amount of that administrative overhead. AI, particular revenue cycle, is seen as an encouraging solution. What roadblocks prevent AI from tackling administrative costs? Mike and Seema really would like to hear from you two on this with kind of the standards tech 1-2 punch. But Mike, I'll start with you on that one in terms of administrative cost.
Yeah, I think we have to. I'm going back to kind of staying focused on the fundamentals. It's a pretty bad system right now between payers and providers, and both parties recognize it. We like to think about standards and data, but the reality is there's still millions of faxes. We're still mailing each other medical records. There's phone calls by the millions between payers and providers just trying to figure out the status of claims. And so we can't build AI and automation on a foundation like that. And so I think a partnership that we keep talking about where we just acknowledge that we have to share data in a standardized way, in a bidirectional way, much more timely is going to be key if we want to really capture the spirit of transformation. I mentioned earlier, but I am encouraged. I think payers and providers understand this, and I'm seeing be encouraged by the good partnerships that are in flight to start addressing this. But it's a bit like crawl, walk, run. We've got to start by getting data and standards. We've got to move to more transparent rules for things like prior authorization, concurrent authorizations, and frankly, authorizations for post-acute care are just as big a problem. And then collectively, I think we can make progress about the harnessing the potential of AI. And it's a miss. I mean, when I think about the amount of transactions that happen between payers and providers, the potential for AI is unbelievable. And so I'm hopeful that with our policymaker in the room and others, that we can continue to strive towards that through a partnership. But AI sits on a basis of good data and standards. And we've got to tackle that first. Then we can start moving forward with, I think, of some really cool ideas around transforming our revenue cycle, the payer's claim cycle. It is ripe for disruption. And payers and providers know that. And now we've got to come together to solve it.
Seema, can technology be the enablement glue that brings everyone together?
I hope so. I'm placing a big bet on it. But I want to go back to the earlier question about government and maybe tie these two pieces together. You know, I think that a lot of times, if we look at the history of healthcare and we look at the history of healthcare legislation, whether it was Affordable Care Act or Medicare Modernization Act, and we've done 50 years of legislation, and but look at where we are. And every time we've said, well, you know, if we cover drugs, then the costs are going to go down. If we cover more people, the costs are going to go down. And if we do this, if we do, you know, that. And at the end of the day, after 50 years, our prices are going up, affordability has gotten worse. And so I kind of asked myself, after spending a lot of time in Washington trying to fix it, what did I really solve? Did anything really get solved? And I think that, in my view, where Washington is now is a little bit of fatigue, right? Where they've put in a lot of work. I think politically, healthcare is really hard because it's what you said earlier, it's like the balloon. You do one thing for one side, the other side comes, you know, so it's really hard when you're trying to make decisions and you do one thing that would help the providers, but then the payers don't like it or pharma doesn't like it. So for Washington, it's so difficult coming up with solutions. And what you see instead is more point solutions where we're focusing on waste, fraud, and abuse, or we're working on coverage or drug pricing, but it's not comprehensive, right? And we know that just doing this one thing or this one thing isn't going to solve the fundamental problems underneath the system that need to get solved. And I don't think our government at this point is going to be able to come in and give us that silver bullet and that panacea. And what you're seeing now is almost like a pushback, right? Where we're seeing the tax credits didn't get approved, you're seeing changes in Medicaid. And so instead of what we've done traditionally, which is expand coverage or put more money into the programs, they're actually moving in a different direction, which is to say, we're kind of exhausted on spending money in healthcare, and we're pulling back a little bit. We're gonna go after waste, fraud, and abuse, and we're gonna push back to force more of that efficiency. And it's from both sides. It used to be that, you know, pharma companies were considered more favorable. That doesn't seem like pharma's under, you know, getting the magic star in Washington. Neither are payers, neither are providers. They're mad at everybody. And I think to some degree, instead of pointing fingers, we're at this moment now where you got to come together to drive that efficiency. That's the only path forward. And so historically, there's been a lot of distrust between payers and providers. I still remember when I was working on prior authorization and we bought both sides in the room together. And I kid you not, like literally the fight broke out. It was like people got very angry just having that conversation years ago. But we look at where we are now. I do think that there's a lot of acknowledgement on both sides where you're saying payers are looking at how much money they're actually spending on prior authorizations, and it turns out that they're actually approving most of the prior authorization requests that come in. They're denying a small amount, but it's creating all of this havoc with the faxing back and forth and papers, and a lot of it's getting approved anyway. And you think about, what is the price of a denial? You're denying all of this care, and then the person appeals, and back and forth and back and forth. By the end of the day, it may have been cheaper to just go approve that thing on the front end. So there's an acknowledgement, I think, of both sides. There's still the distrust that as providers are starting to implement more rev cycle AI agents or even ambient listening, that's creating upcoding, right? Is it upcoding or is it accurate coding? Who knows? So I think there's some, you know, it's going to take us some time to trust each other, but I think both sides can acknowledge that we're both spending way too much time on administrative costs. The amount of people in the back room just to do a prior auth, utilization management, the amount of people that are standing around a fax machine. I mean, you know, they have to train medical students on what a fax machine is, much less how to use it, because it's so antiquated, right? So there's an enormous opportunity. The other thing I would say is that I wouldn't underestimate the power of AI. We've been talking about standards for a long time. It's very possible that the AI doesn't need the standard. It can read multiple things. And I think there's an opportunity now for us to completely re-envision how we do these transactions. You know, we may not need the 820 and the 834 and the this, that, and the other thing. It's very possible that AI can read what's going on from the medical record and do all the transactions right off of the electronic health record and really reducing a lot of our administrative costs. We're always going to need humans because you're going to need a human in the loop to make sure everything's, to supervise the AI. But I think we're at a historical opportunity if both sides can come together and are committed to reinventing the future, knowing that we don't have the type of support in Washington that we've had historically.
I think what you said, one of the statements you said is so critical. I think the way people think about standards can be really impactful. Outside of healthcare, standards are usually something that's thought of that you create that allows innovation to constantly come in. They aren't tech dependent, you apply tech to it. And so having that agility to move, you see that in finance, you see that in tech, healthcare. That has been something I think that has held the industry back, and hopefully we'll see progress going forward. That's one of those great positives of non-traditional stakeholders coming in. So I'm really excited. Casey, when you hear these conversations about standardization, at some point that probably requires a regulatory hook for it to really get its grips in to force change. Kind of going back to the earlier comment that we had about where the government does and does not come in, self-organizing at the industry around standards that has been common in other industries, is that something that the government would be looking for to occur? Is there a push to really want people to take more of a lead on the industry side in that space?
Yeah, well, there's also a gray area in between there. This is the 250th birthday of our country, and you go back, our founding fathers couldn't imagine so much what our government does, but setting standards is something they could imagine. They were measuring weights and things like that so many different ways, and it was totally a legitimate role of government for standards. It can be tricky. I've seen from my small business perspective that when industry will be involved, there may be industry standards that the government will adopt, but who set the industry standards? The bigger companies, and the smaller companies never got a say in that. So that it's not as straightforward as it first may seem, but there's no doubt that there's a role for government setting standards. Look at price transparency. There's a lot of controversy around that, but one of the things that we've done is say, look, here's the standard. When you publish your prices, here's a standard way to publish them so that consumers and employers and plans can compare. They're going to be looking at multiple providers, and they're all using the same standard. It helps make the transparency system work.
Scott, let's go to the payer-provider friction. What's it going to take to get everyone sitting across the table from one another?
Yeah, I think we touched on that well this morning already. We mentioned administrative costs as a shared opportunity. We've mentioned sentiment is not in any of our favors. And so will that force us to the table? I am encouraged by that. I would say probably longer term. So in the short term, what likely most of the folks are feeling is some version of a prior auth conversation happening. Observations is all of a sudden a conversation again, to midnight rule, denial of cases that are 4 to 5 days in a hospital being denied. And so in today's environment, we in the industry are adding fuel to that fire that's already burning, right? But I do think the outcome of that, I am optimistic that the outcome of that is with certain payers that will break the ice. And while I think AI and technology is a solution, particularly short-term for administrative cost, the level of conversation we're having is, in everyone's favorite example of bot versus bot, provider revenue cycle bot against the denial insurance bot. Is the fundamental problem the distance of time needed to adjudicate or pay a claim? There was a conversation earlier today, I think somebody's remarks said that there should be a competitive friction, tension, about what the right clinical protocol is. I would say that's true. It can't be when the consumer is deciding on care or in the middle of that care. That's not the time for the debate. The time for the debate is before and maybe after. And so I do think there are a handful of payers willing to have that debate because of the administrative cost, because of probably the global sentiment. I want to believe also because of differentiation. The idea that there is a different model that will win over the public, we can gain that trust back, and the feeling that we're only going to be able to do that together. And so we need providers, payers, who are bold to make that step together.
So, Jason, when you hear payer-provider friction, conflict, do you kind of roll your eyes and be like, man, we're over this?
Well, I mean, the beautiful thing about everybody in this room, back to the question of human beings, we've all been on the other side of that conversation with our mom or our child, where we get that piece of paper and we're like, I mean, I know the system and I can't even navigate it myself. And we know where the problems are stemming from, right? And it's going back to, I think, some of the things we talked about. We have still been a primarily cause-based, responsive healthcare system. It's like you said, it's about this cause or that cause or this cause. We haven't thought about it from a need. And so when we look at it from the lens of the way that a person approaches healthcare as a consumer, the fact that they feel left alone in navigating a system that they feel was built by somebody else for the needs and the efficiencies of that system has people left helpless, right? And I think the reality is, how do we get from this idea of cause to need? And I do feel like, I think you've all said it in some capacity, we've had to just operate our healthcare systems to survive the way we've built this structure. And in many ways, that leaves out the consumer voice. I don't know any other industry that doesn't at least understand how their consumers engage with them. We approach healthcare from, well, we want them to get quality outcomes. We want them to be able to have access. We think about all the things that are right, but we often don't realize just their understanding of the system makes it really hard for us, all of us as patients or family members, to even engage in an effective way. So my biggest concern in that conversation is we'll redesign a perfect system, but we still won't have it work for the people that need to step into it. And so the conversation I think that you're trying to generate around bringing people together needs to actually think about the end user first. And I don't think we do that really well yet in healthcare.
So I go to a lot of conferences, obviously, all year round, and I have yet to be at one this year where the focus wasn't AI. So SEMA, as this is moving fast, right? People are going from experimentation to operational reality really, really quick. What risks should health leaders keep top of mind as they're looking to actively manage this transition? What advice can you give them?
Sure. So I think number one, make sure you have a strategy to bring your data together, right? You can't have an AI strategy without having a data strategy, number one. Number two, kind of consider, do I want to embed the AI into my applications or do I want it bolted on? Thinking about how all the AI is going to work together, right? So not maybe thinking about purchasing decisions for rev cycle without thinking about the clinical part or thinking about the patient experience. It all sort of has to work together. So I would say taking a comprehensive approach. The other thing is that not all AI is created equally, and so really pushing on vendors, demanding the KPI, demanding the return on investment. I think at this point, healthcare has been burned by tech enough to say, if I'm going to make this investment, I want to know that this is the type of ROI that I want to see. And I think that that's fair game. Looking at safety and trust in AI. How is that model trained? How is the model monitored? And this isn't monitoring where we're going to take a look at it every year or every 6 months. Models need to be monitored on an ongoing basis. They can drift. They can move in different directions. So we have to make sure you have that with whoever you're working with, that they have that sort of safety AI structure in place. And look, the government may come and put regulations and more transparency around it, but in the meantime, you've got to ask those questions. What is your policy? How is it developed? How is your AI? Which models are you using? How is that model taking in real-time data? One of the things that we see a lot of is, our AI model was built on 13 years of historical data. Well, that sounds great, 13 years of historical data. And it's like, well, wait a minute. What happened? We weren't practicing medicine the way we were 13 years ago, and the rules have changed. So you also want to make sure that the AI has the capacity to bring in context and live evergreen data, that it's not just using older data. So it's using your data, but it's also bringing in evergreen data externally. So there's a lot of components to it, but I think thinking through it in a more comprehensive way. And I would challenge, for my company and for every other one, it's like put your money where your mouth is. They've got to deliver returns this time when it comes to healthcare, because I don't think that healthcare can afford to make investments in AI or any tech that isn't delivering savings, right? You got to do the job better, but you also got to bring down my costs, because what we have today isn't sustainable. And the idea that healthcare systems are going to keep their technology that they have today and then layer on additional costs and hope that it delivers an ROI. It can't be a hope. It has to deliver.
Scott and Mike, any advice to the financial leaders out there navigating all this, lessons learned from either one of you?
We did. We probably started, like most providers, started with governance. Do we know where it all is, or is it bring your own AI to work? And so I'd say we'd probably start from that perspective. Think we did probably reasonably good on that. That also created an atmosphere of encouragement. So what would we as an enterprise encourage you to use in the day-to-day work, trying to get to that people connected to AI conversation? How do we get folks using it? How do we get them comfortable with it? So I'd say success there. We, like many others, between ambient revenue cycle, a lot of, on an ERP side, have exercised our muscle administratively with the use of AI. And then I'll say a light touch to date relative to consumer patient navigation and clinical. To me, I do think it was a chance for us to drive the ROI conversation inside our enterprises. The old days of green dollars and blue dollars and pajama times and those types of things, I think this provided a good forum to say, no, it has to have return because we see this as fuel that's going to continue.
Yeah, I think that's right. I mean, we got organized early to make sure we not only had the right strategy, but the right administrative process to govern the delivery of AI. We break our work up into clinical first, because that's our focus. We have a lot of work in our operational platform, and then a lot of work administratively, as Scott talks about. I mean, I mentioned it as well, but supply chain, rev cycle, IT, human resources are transactional, and there's a lot of opportunity in AI in those areas. But you got to prioritize, and you got to drive to a return on investment. Scott said that's key, but you got to organize to do that. And it's not just finance, it's outcomes, it's clinical, it's service, it's workforce. You know, a lot of the payback here is reducing turnover and reducing administrative burden with workforce. So I think that's key for sure. My only other comment, because I think everything that Seema and Scott have said is right on, but change management is key. Frankly, my experience, our experience, is that adopting and driving change management and getting people to use digital products is far harder than building them. And so building that capability of implementation and change management throughout your organization is a really big part of AI.
Jason, AI, consumer expectations, what big trends are changing?
Yeah, AI, AIO. The reality, I think, is that most people are used to AI in some capacity now in their own human lives, right, in their day-to-day lives. I do think when we ask the U.S. consumers what they thought, there's still it gets stuck in the trust conversation a lot. So there's still 45% of people that don't want to have an experience with AI as a consumer in healthcare today. They don't disagree it should be used to make their processes better or the things that happen behind the scene. But I do think we have a huge education gap opportunity. So not only how do we ensure that we're using it effectively in the ways that you all spoke to internally, but how are we communicating to the folks who walk in our door to receive care, how it's being applied to what's going to help them get better care overall. And that seems to still be a missing opportunity that we have. So not just how we do it well internally, but how do we communicate to our communities how we're using it to help them actually have better outcomes as well.
So final question for the panel before we go to some closing comments. How can industry leaders better connect the conversations of financial sustainability in institutions and affordability for the consumer? I'll open it up to anyone that would like to comment on that one. What can we do to better bring these two things together?
That's easy. That's an easy one. Innovation. I mean, discover ways to make things cheaper. That's good for the company who discovers how to make things cheaper, and that goes to the consumer pretty quickly through the market process.
Yeah, I think we've got to make affordability real. And if you're, my sense is, and we take care of patients every day, that affordability kind of comes down to, can you afford the care that you need? When people can't afford the care they need, they delay care. And then when they re-engage with the healthcare system later, they're sicker, they're in the emergency rooms, and this is not nearly what we're all trying to search for in terms of the care and improvement of human life, which is broadly our mission. And so, You know, I think affordability has to become practical. It has to be efficient, it has to be effective, it's got to be timely, and it's got to be more transparent. And I think as a group, you've heard us talk about those themes here today, and I think that's the right way to think about it.
I do. I could add real quickly. We are so all of us are so mission focused. I do think we have a compelling argument that in our communities there is overwhelming demand for our service. We are not going to do that by continuing to oversupply. Whether you'd say we don't have the time, whether the affordability issue is there, how are we going to meet that demand? And so I think that's going to require innovation. I think it's going to require a different approach. And we're going to need to be more accessible. That means affordable. Same thing as affordable. Yep.
Seema?
I don't think that, nothing in healthcare is disconnected. I think that's part of the problem is that we're trying to solve problems. We're going to go solve this one over here and this one over here, and they're all connected. So you really have to have a comprehensive approach. But so when we talk about affordability, right, you can't talk about affordability when you're not talking about efficiency. So it's all connected. I think the issue becomes, at this moment in time, what is going to drive this forward, right? Is it drug pricing? It's going to be this. It's not one thing. It's comprehensive.
Yeah. So we're at time, but I'm going to give the last word to Jason. You're sitting here representing the patient voice. Based upon what we've said today, how are we doing? What do you think we hit out of the park? What do you think we're missing?
I mean, I think we get it. I mean, I think that's a reality. I mean, Mike and I were talking, we've known each other for 20-something years when we worked together. I mean, I know folks get it, right? And do we have any old New Yorkers here in the room? I mean, does anybody remember Sims, the clothing store Sims? There was this ad he would put on that said, an educated consumer is my best customer. And it was because when you knew how to navigate the system, you could use it the best way possible for yourself. And I do think that we have an opportunity, because we have these conversations among ourselves. I would love to challenge everyone to figure out how we have these conversations with the people we serve, because they actually have answers and thoughts and ideas. They bring the innovations and the potential efficiencies. Yes, we have to navigate the complex system we have, but how do we ensure we create an educated consumer in the United States that actually plays a part in system transformation? And I do think that's an opportunity to kind of put on our backs. Like you said, we can put access out there all day long, but if it's not what people are going to actually access, what good did it do? And so I do think we have a huge opportunity to listen beyond our own circles in a way that's meaningful and impactful to drive the outcomes that we're trying to achieve each day. So.
Well, one thing that is true in these dynamic times, it takes real courage to be a leader. And so I want to thank all of our panelists here for being tremendous leaders of this industry to forge ahead and create a better future for everyone. Thank you for your work. Thank you for being a part of AC26.